Good morning, everyone, and thank you for being here today. I'm pleased to introduce our presentation on calculus cholecystitis. My name is Dr. Asim Hussein. We'll be exploring the key aspects of this condition, including its causes, diagnosis, and management. Over the next few minutes, I'll guide you through the important points you need to know. Let's get started. Let's look at this clinical scenario. We have a 67-year-old man who's currently ventilated in the ICU due to septic shock. He's developed a fever, his inflammatory markers are rising, and he has unexplained hypotension. Since he's sedated, he can't report any pain himself. His liver function tests, or LFTs, are only mildly abnormal. Now, the key points here are the setting, ICU, septic shock, and the fact that he's sedated, so we can't rely on his pain report. Also, the mild LFT abnormalities suggest some hepatic or biliary involvement, but not severe enough to point to a specific diagnosis directly. Given this context, it's crucial to think about which condition among these options is most consistent with his presentation. The focus is on recognizing the clinical clues that point toward one diagnosis over the others. Throughout this presentation, we'll explore how different hepatobiliary or pancreatic conditions present, especially in critically ill patients, and how to differentiate between them based on clinical and laboratory findings. The correct answer here is C now. Let's delve into why that's the case. Acalculous cholecystitis typically occurs in critically ill patients who are fasting and often on ventilators. Unlike the classic gallbladder inflammation, which presents with right upper quadrant pain, acalculous cholecystitis can be more elusive. In these cases, patients often don't show the typical symptoms. Instead, the presentation is more subtle and more concerning, sepsis of unclear source. This means that instead of the typical pain, the patient may just be deteriorating rapidly with signs of systemic infection, making diagnosis trickier. Understanding this helps us recognize the importance of considering acalculous cholecystitis in critically ill patients who suddenly develop sepsis without an obvious source, especially when they're fasting or ventilated. It's a key point that ties into the overall theme of recognizing atypical presentations in critical care. Now, let's move on to the next question. Here, we're asked to identify which ICU factor most strongly predisposes patients to acalculous cholecystitis. As we look at the options, it's important to remember that acalculous cholecystitis isn't caused by gallstones, but rather by other factors that lead to gallbladder inflammation. Options like total parenteral nutrition and prolonged fasting stand out because they can cause bile stasis, which is a key component in the development of this condition. Similarly, alcohol excess, hypertriglyceridemia, and autoimmune diseases are relevant in different contexts. But in the ICU setting, the most significant factor tends to be related to the patient's nutritional status and mobility. So, when we think about ICU patients, especially those on prolonged fasting or TPN, the lack of normal enteral feeding can really impair gallbladder emptying, creating an environment ripe for inflammation. This connection highlights how critical nutritional management is in preventing complications like acalculous cholecystitis in our critically ill patients. The correct answer here is B now. Let's delve into why. Biliary stasis, which is essentially the slowdown or stoppage of bile flow, can occur due to several factors like fasting, total parenteral nutrition, shock, and immobility. When the gallbladder doesn't empty properly, bile can become stagnant. This stagnation predisposes the gallbladder to ischemia, meaning reduced blood flow and inflammation. Importantly, this process can happen even without the presence of gallstones. So, in patients who are fasting or critically ill, the risk of developing inflammation of the gallbladder, acute cholecystitis, can arise purely from biliary stasis and ischemia, not necessarily stones. This highlights a key concept in understanding gallbladder pathology. Not all cases involve stones. Some are due to these systemic or functional factors that impair normal bile flow. Connecting this to our overall theme, It emphasizes how systemic conditions and patient management strategies directly impact gallbladder health and disease risk. All right, let's take a look at this clinical scenario. We have an ICU patient, which already suggests the patient is critically ill, and there's a suspicion of Acalculous cholecystitis. Now, when we're considering imaging options, it's crucial to choose the most appropriate first-line modality. From the options listed, CT abdomen, MRCP, abdominal ultrasound, ERCP, and HIDA scan, we need to think about which provides the most reliable initial assessment in this context. The key here is that in critically ill patients, especially in the ICU, we want a safe, readily available, and quick imaging method. Abdominal ultrasound is often the go-to first step because it's non-invasive, doesn't involve radiation, and can be performed rapidly at the bedside. While CT scans are also useful, they are generally secondary or confirmatory, especially if ultrasound findings are inconclusive. MRCP and ERCP are more specialized and typically reserved for detailed biliary imaging or therapeutic procedures. The HIDA scan is sensitive, but less practical in unstable ICU patients due to longer imaging times and limited availability. So, in summary, for an ICU patient with suspected Acalculous cholecystitis, the most appropriate initial imaging modality is abdominal ultrasound. It aligns with the overall goal of prompt, safe, and effective diagnosis. The correct answer here is C when it comes to diagnosing gallbladder issues. Ultrasound is actually the first-line imaging modality we use. It's particularly good at identifying key features like gallbladder wall thickening, distension, the presence of sludge, and pericocystic fluid. These findings are critical clues pointing towards conditions like cholecystitis. Now, while ultrasound is our go-to, there are times when its results are not definitive. That's when CT scans come into play. They're useful if ultrasound results are equivocal or unclear. CT can provide additional detail and help clarify the diagnosis when needed. Overall, understanding the strengths of ultrasound and knowing when to escalate to CT ensures we accurately identify gallbladder pathology, which is essential for guiding effective treatment. All right, let's look at this scenario. We have a ventilated patient with suspected Acalculous cholecystitis who is septic and hemodynamically unstable. This situation is quite critical, and it requires immediate action. Now, among the options, we need to think about what is the most appropriate initial management. Elective laparoscopic cholecystectomy, which is option A, wouldn't be suitable here because the patient is unstable. Surgery at this point could be too risky. Conservative management alone, option B, isn't enough in a septic, unstable patient. Waiting could worsen the condition. Percutaneous cholecystectomy with antibiotics, option C, is often used as a bridge in unstable patients. It allows for drainage of the gallbladder and stabilization before definitive surgery. ERCP, option D, is typically reserved for cases with bile duct stones or cholangitis, but not as an immediate step in this scenario. Oral antibiotics alone, option E, won't provide the necessary drainage or rapid relief needed here. So, considering the urgency and the patient's instability, the most appropriate immediate management is to perform a percutaneous cholecystectomy combined with antibiotics. This approach helps control the infection quickly and stabilizes the patient for potential definitive treatment later. The correct answer here is C now. Let's talk about why that is. Percutaneous cholecystostomy is actually the preferred approach in unstable ICU patients. This procedure allows for source control without the need for major surgery, which can be risky in critically ill patients. It's a minimally invasive option that helps manage the infection effectively while minimizing additional stress on the patient. This point really ties into the overall theme of tailoring our interventions to the patient's stability and condition, ensuring we choose the safest and most effective approach in complex cases. Now, let's take a look at this question. We're asked to identify the most serious complication resulting from a delayed diagnosis of Acalculous cholecystitis. As you can see, The options include chronic gallstones, gallbladder perforation and gangrene, cholangiocarcinoma, portal hypertension, and pancreatic pseudocyst. The key point here is that when acalculous cholecystitis isn't diagnosed promptly, the inflammation can become severe. This can lead to tissue necrosis, which may cause the gallbladder to perforate or develop gangrene. Among all these options, the most feared complication is gallbladder perforation and gangrene because it significantly increases the risk of peritonitis and sepsis, which can be life-threatening. This highlights the importance of early detection and management. Remember, delayed diagnosis can escalate a relatively manageable condition into a serious emergency. So, in this case, the correct answer is B, gallbladder perforation and gangrene. Let's take a closer look at the correct answer, which is B now. The key point here is acalculous cholecystitis. This condition is particularly concerning because it tends to have high rates of complications like gangrene and perforation. These complications significantly increase the risk of mortality if the diagnosis is missed or delayed. So, understanding this helps us appreciate why early recognition and prompt management are crucial in these cases. It also ties into the overall theme of the presentation, emphasizing the importance of proper diagnosis to prevent severe outcomes. Today, I want to talk about a specific type of gallbladder inflammation known as acalculous cholecystitis, particularly in critically ill patients. As the name suggests, this condition involves inflammation of the gallbladder without the presence of gallstones. This distinction is really important because it changes how we think about the causes and management of the disease. In critically ill patients, especially those in the ICU, this form of cholecystitis can be quite challenging because it often occurs without the typical stones we usually associate with gallbladder problems. Instead, it's often linked to factors like ischemia, stasis, or systemic infection. Understanding this condition is crucial because it highlights the importance of maintaining vigilance in our critically ill patients. Recognizing that gallbladder inflammation can occur without stones helps us consider it in our differential diagnosis when patients develop abdominal symptoms or signs of infection, even if imaging doesn't show stones. So, in summary, acalculous cholecystitis in the ICU setting is a significant, often under-recognized cause of gallbladder inflammation, and understanding its key features helps us provide better care for our most vulnerable patients. Now, let's take a look at a typical setting where acalculous cholecystitis often occurs. It's usually in critically ill patients who are in the ICU, often ventilated and sedated. These patients might be post-surgery, have suffered burns or trauma, or be dealing with sepsis. In such cases, the gallbladder isn't inflamed due to stones, but rather because of other stress-related factors. This condition, called acalculous cholecystitis, is especially common in ICU patients because their critical state predisposes them to gallbladder inflammation without stones. It's important to recognize this because the presentation can be subtle, and these patients can't always communicate symptoms clearly. So, understanding the typical ICU setting helps us stay alert for this diagnosis, which requires prompt management to prevent complications. Let's now take a look at some of the key risk factors that can contribute to complications like biliary issues. First, prolonged fasting or total parenteral nutrition, or TPN, can lead to decreased stimulation of the gallbladder, which increases the risk of stasis and inflammation. Next, hypotension and shock can impair blood flow to the biliary system, making it more susceptible to injury and infection. Mechanical ventilation is another factor. It can influence abdominal pressure and affect gallbladder function. Opioid use is also significant because opioids tend to cause biliary stasis by relaxing the sphincter of Oddi, which can sometimes lead to bile buildup. Lastly, in the ICU setting, we see cases of acalculous cholecystitis, where inflammation occurs without gallstones, often related to critical illness and the factors we've discussed. Understanding these risk factors helps us recognize which patients are more vulnerable and emphasizes the importance of careful management to prevent these complications. Let's talk about some of the clinical features we might encounter. Often, there's an asterisk, often silent abdomen asterisk, meaning patients may not show obvious signs of discomfort or pain, which can make diagnosis tricky. Another key point is unexplained sepsis or fever, coupled with a rising CRP, indicating an inflammatory process that isn't immediately clear. We also see mild liver function test derangements, which might suggest some level of hepatic involvement. In ICU settings, a specific condition to keep in mind is Acalculous cholecystitis. Unlike typical gallbladder inflammation caused by stones, this occurs without stones and is often linked to critical illness or severe systemic infections. Recognizing these features is crucial because they highlight how subtle and nonspecific some of these signs can be, yet they're essential clues when considering diagnosis within the broader context of systemic illness. When it comes to diagnosing gallbladder issues, ultrasound is our first-line imaging modality. It's quick, non-invasive, and quite effective. On ultrasound, we look for gallbladder distension, which suggests that the gallbladder is enlarged, possibly due to inflammation or obstruction. We also check the wall thickness. If it's greater than 3 to 4 millimeters, that's a significant sign of inflammation. Additionally, the presence of sludge inside the gallbladder or fluid around it, known as pericholcystic fluid, can further support the diagnosis of cholecystitis. If ultrasound results are inconclusive or unclear, a CT scan can be very helpful. It provides more detailed images and can help us identify other possible causes or complications. Now, when we talk about Acalculous cholecystitis, especially in ICU patients, the diagnosis can be even trickier because they often don't have gallstones. In these cases, the clinical suspicion combined with imaging findings like gallbladder wall thickening, distension, or fluid accumulation is crucial. So the key takeaway here is that ultrasound remains our first choice for diagnosis, focusing on these specific features, and CT serves as a valuable follow-up when ultrasound doesn't give us a clear answer. This approach helps us identify and manage gallbladder inflammation effectively, even in more complex cases like those in the ICU. Now, let's talk about management strategies. For most cases, broad-spectrum IV antibiotics are essential to cover the potential bacterial infections. In unstable patients, especially those in the ICU, a percutaneous cholecystostomy can be a lifesaver, providing immediate relief when surgery isn't an option right away. Once the patient stabilizes, we typically plan for an interval cholecystectomy to definitively treat the problem. Moving on to Acalculous cholecystitis, which is more common in critically ill patients, the approach is similar but often more urgent due to the higher risk of complications. The key here is prompt diagnosis and tailored management, often involving both antibiotics and drainage procedures. This slide highlights how our overall goal is to control infection quickly while carefully timing surgery, especially in unstable or critically ill patients. Now, let's discuss some of the high-risk complications that can arise in severe cases. First, gangrene. This occurs when the tissue in the gallbladder or surrounding areas dies due to a lack of blood supply, which can be life-threatening. Next, perforation. This is when the gallbladder wall tears, leading to the release of bile and infection into the abdominal cavity, potentially causing peritonitis. Then, we have empyema, which is essentially a collection of pus within the gallbladder, indicating a severe infection that requires urgent attention. Lastly, Acalculous cholecystitis, often seen in ICU patients, occurs without gallstones but still involves inflammation of the gallbladder. Recognizing these complications early is crucial because they significantly increase morbidity and require prompt, aggressive management. Connecting this back to our overall theme, understanding these risks helps us prepare for and prevent severe outcomes in our patients. Let's look at an important exam pearl here. When you encounter unexplained ICU sepsis and there are no gallstones present, you should think about Acalculous cholecystitis. This condition is particularly relevant in critically ill patients, especially those in the ICU. Acalculous cholecystitis is an inflammation of the gallbladder without the presence of stones. It often presents with nonspecific symptoms, which can make diagnosis challenging. The key point is that in the ICU setting, when sepsis occurs without an obvious source and gallstones are absent, this diagnosis should be high on your differential. This condition is serious because it can lead to gallbladder necrosis or perforation if not recognized and treated promptly. So always keep this in mind when evaluating ICU patients with unexplained sepsis. Consider acalculous cholecystitis as a potential underlying cause, especially when imaging or clinical clues point toward gallbladder inflammation without stones. Thank you so much for your time and attention today. I truly appreciate you being here and engaging with the material. I hope that the insights we've shared have been helpful and inspiring. Remember, the key points we've discussed are not just ideas on a slide, but practical concepts you can apply moving forward. Your participation and curiosity are what drive progress and innovation. So, thank you once again for being part of this journey. I look forward to seeing how you take these ideas and make a difference. Have a great day.